Thank you very much indeed for the invitation to moderate this table. It is a real pleasure for me to moderate friends and people I admire deeply. My name is Julia Del Amo, and I work in the Health Institute Carlos III and in epidemics. And I'm going to introduce the first of our speakers, who is Professor Jürgen Rostock. He's very well known, and anyone who works in HIV knows him. He's a researcher and a doctor, an excellent doctor. He's an activist and a person who always stands from the crowd. He's fun, funny, intelligent, and has a research line along with hepatitis C. He's a world leader, so we have the pleasure of listening to him. He's going to start talking about the co-infections related to HIV. So he's going to give us a general view of the situation right now. The next speaker is Professor Mallon. He's the infectious disease specialist in the University Hospital in Dublin. Not only he's a specialist in infectious disease, a doctor, but he's also a researcher, and he's going to introduce what's happening with HIV and aging. A very good piece of news and some challenges that he's going to present and forward ways of approaching it. And lastly, given that we are in Madrid and Santi is a very good friend and I am a great fan of him, so if you don't know him, you have a reason, even more special, to listen to him, because Santi is a person, is a reference icon in Spain and outside Spain. And for us, is an inspiration, somebody who helps us, supports and embraces constantly, as you all know. Santiago is a professor, is a university professor, is the chief of infectious disease in Ramón y Cajal Hospital, and is as I said, is a person very important in this field. He's going to talk about healing in HIV, which is a longing we all aspire to, and very few people talk about this in such a simple manner and terms. We have an hour and a half session, so each speaker will talk for about 20 minutes, and then we will all get together and we will ask questions and we'll have a dialogue before the lunch break. This is all. Jürgen, the floor is yours.
Great to be here, and I have to say we spent a wonderful weekend in Madrid. We enjoyed World Pride, and yesterday was really a highlight. We went through all the tapas bar and saw how many tapas can one person eat, and that's why we are so big, because we had so many tapas yesterday with wonderful red wine, and it was really a treat. Now, despite all the fun and the enjoyment, there are things community has to know. Also from a medical perspective, things which are important in the context of HIV, but also important in the context of MSM altogether. And so I accepted this talk because I really think it's something we all need to know about and think about and what we can do to prevent some of these co-infections. So in order to speak just 25 minutes and longer, I have focused on hepatitis A, B, C, and HBV, which are all common infections found in patients with HIV, but also outside of the context of HIV. Now, the first thing to say about viral hepatitis is that annually 1.45 million people die because of viral hepatitis. So if you have chronic hepatitis over many years, liver fibrosis can form, and that can lead to liver cirrhosis, what you may know also in the context of alcoholic liver disease. And that, when the liver doesn't function at all anymore, that is not sustainable, and people die from liver disease. And the amazing thing is that viral hepatitis has become the 7th most prominent cause of dying. So that is a very prominent cause, so a very commonly found cause of death, and accordingly very important. Now, hepatitis A, when you look up in the internet or in textbooks, they usually say this is caused when people do not wash their hands after using the toilet and then touch or prepare other people's food. And it's commonly found after eating mussels or salad in North Africa, which is not washed properly. But it's also, and that's always missing, sexually transmitted. And usually then the question of the audience comes, well, how is it transmitted? And then someone says, it's rimming. And then someone says, what's that? So it is an issue, and it is something which is transmitted very easily. And obviously it's all dependent on level of vaccination, but we'll talk about that. And then you have hepatitis B and C, which can be spread by an infected person without a condom, sharing needles when doing drugs, needle sticks, or from an infected mother to her baby. And these are all relevant issues.
Let's start with hepatitis A, and then you can build hepatitis.
Greek, and the itis always stands for inflammation, so it's inflammation in the liver. And how do people recognize they have hepatitis? Usually because they become jaundiced, so they are yellow, and when you look into their eyes, other than taking atazanavir, which is obviously another option, but on average, when you turn yellow, you have hepatitis, and that's indicative of liver disease, and that's when you need to see a doctor and look at what's happening. And this is difficult to read, but I think of great interest. So this year, there have been already 2 major reports on outbreaks of hepatitis A among men who have sex with men from England and from the Netherlands. And note that this was happening last year at Europride. So now we have World Pride, last year we had Europride. And it tells you that when men come together to have a good time and a lot of sex is happening, there is transmission of hepatitis A. And that's a real concern because hepatitis A is preventable. You can get vaccinated. So every gay man should be vaccinated against hepatitis A and B. In most healthcare systems, it's free of charge if you have that corresponding risk for infection. Usually after 1 injection, you already have an almost 90% protection rate. It's a little bit lower in the context of HIV. Usually 2 vaccination steps are required, but it is preventable. And it's now happening all over the world. We were just at a co-infection conference. There were outbreaks now in Portugal, in Germany, in Italy. It's happening everywhere. It just tells you that once the level of vaccination rate goes down, people become prone for this infection. Now, fortunately, hepatitis A does not become chronic. So you can become very sick, you can have high liver enzyme elevation, but in the end, it's very unlikely to die, and you do not develop chronic liver disease. So it is in the end manageable, but you don't want to spend a week or 2 in hospital, and it's avoidable. All right? Once you went through a hepatitis A, you have lifelong protection. So in the European guidelines, the general recommendation of viral hepatitis assessment is that when you have HIV, everyone at his first visit should be checked for hepatitis A, B, and C. And if you are having a negative hepatitis A and B serology, you should be vaccinated against the 2. If you only have a negative hepatitis B serology, you will only get vaccinated against hepatitis B and so forth. There is no vaccination for hepatitis C. So let's move to hepatitis B. Hepatitis B is different than hepatitis A because it can become chronic. And around 9% of all HIV patients also have hepatitis B. Chronic hepatitis B is defined as persistent hepatitis B antigen detection. So if you have ongoing signs of the virus in your body, then you have chronic hepatitis B. You see it is more commonly found in some of the southern countries. It's also very endemic in Asia, where you probably have the highest rate, as well as in Africa. If you have HIV and get hepatitis B infected, your probability of having chronic infection is 6 times higher than if you are not HIV infected. So again, vaccination is an important issue. In the early days of HIV, we didn't worry much about hepatitis B because we were worried about HIV diseases and getting sick with pneumonia and all these things. But then we learned, once HIV became treatable, you suddenly had a high risk of dying from liver disease when you had HIV and hepatitis B. And that risk was much higher than if you only had HIV or only had HBV. So HIV, particularly with low CD4 counts, drives the progression of liver disease, and it becomes a real relevant issue. That's why hepatitis B really needs to be prevented, at best by vaccination. And if you get treated, and it doesn't matter how it is, but anyone who gets HIV therapy should have inclusion of a drug which works against HIV and HBV. So many of the HIV drugs also have activity against hepatitis B. So if you use tenofovir in particular or TAF, then you have complete therapy of hepatitis B. So in general, every patient in Europe who has chronic hepatitis B and HIV will receive a tenofovir-containing regimen. There are other agents like 3TC or FDC which also contain anti-HBV activity but are more prone to resistance development, so tenofovir really needs to be on board. And once you have a dual active HIV-HBV agent in your therapy, you can see on the right-hand side end-stage liver disease-associated death, so people dying from liver disease, dramatically decreased and almost disappeared once these agents became available. So telling you the benefit of therapy is huge because it can prevent advanced liver disease and dying from liver disease very effectively. And one of the most fascinating things also in the context of PrEP is that the Dutch colleagues said, well, if PrEP can sort of maybe play a role in preventing HIV, maybe tenofovir also has a role in preventing hepatitis B. So they looked at their cohort in Amsterdam, and it's a true, I think, real-world reflection. So you have thousands of patients in the MSM cohort of Amsterdam, and they found there are many who already had a past hepatitis B, so they have immunity. They saw they have some patients who were vaccinated successfully, but they have a remaining group of around 30% who were not vaccinated and never had hepatitis B. So they remain at risk for hepatitis B. And when they looked at that group and looked at those who had tenofovir as part of their HIV regimen versus those who had no tenofovir in that regimen, you can see that no one with tenofovir in the regimen got infected with hepatitis B, whereas patients who did not have an HBV agent, there were regular rates of infection, telling you that if you take tenofovir, it will prevent hepatitis B. So if you're not vaccinated, at least if you're on tenofovir, you have a protection against hepatitis B. And that's an important issue because I think also in the context of PrEP, that will also prevent against hepatitis B infection. So I think that's at least one good news of the tenofovir-based regimens we have. So tenofovir is not only the best option for treating patients with hepatitis B, it's also preventive for those who have not acquired the infection so far. The viral hepatitis with the biggest concern, though, worldwide is clearly hepatitis C. And the difference is that hepatitis C has a much higher risk of becoming chronic. So you only have, if you're HIV positive, only a 15% chance of clearing the infection spontaneously. So 85% develop chronic infection. And it's estimated that around 2.3 million people who have HIV also have co-infection with hepatitis C. It is found globally everywhere in the world, and it's particularly high in patients with intravenous drug use. So traditionally, if you share needles and someone has hepatitis C, the risk of becoming infection is very high. And in most cohorts of IV drug users, the rate of co-infection with hepatitis C and HIV is over 80%. So in Russia, where IV drug use is the main driver of the epidemic, around 70 to 80% of people with new HIV diagnosis also have hepatitis C. In the MSM population, this was not a concern when HIV appeared. So in 1981, 1982, 1983, very little hepatitis C, only in those who were also IV drug users. But this has changed, so we now see a much higher rate, and we'll talk a little bit more about that in a minute. So the risk of acquiring hepatitis C in HIV-positive individuals is 5.8 times higher. So there's a real relevant risk of getting hepatitis C infected. And you can see that the risk is higher than in any other group except prisoners. And the problem with prisoners is, obviously, there are many countries in which they say if you're in prison, there is no drug use. We all know that there is drug use in prison. And so people share needles in prison because of the difficulties of getting free access to opioid substitution and needle sharing, and that's why the risk in prison is the highest for all hepatitis C infections. But you can see that MSM also now have a 7.5-fold higher risk of acquiring hepatitis C. So that is something which is new in the community and something we have to think about. So a colleague in my group has put together all the published cases of outbreaks of hepatitis C among gay men in the world. And the fascinating thing is that the first reports of outbreaks of acute hepatitis C among gay men was in London in 2002 from the Chelsea Westminster Clinic. Then there were reports in Amsterdam, Berlin, and Paris. So in large gay communities, it was spreading. We were able to show that it was linked phylogenetically, so people were going to sex parties in different places, sharing viruses. And then what you see, though, is it's something which spread over the entire world. So you can see it's now happening in the US, in Australia, and also in Asia. And these viruses are not genetically related. So it's not like someone from Taiwan went to Berlin and had a wonderful evening. No, it's a different setting in which they acquire their infection. But it tells you something's happening in the gay community at the same time at different places. And it raises the question, obviously, of why is that happening now and how is hepatitis C transmitted? And of note, with PrEP being rolled out, I think the opportunity arises to check HIV negative MSM and to see how high is already the burden of hepatitis C in this group. And you see that in Amsterdam, people who asked for PrEP and went into the demonstration project, already 4.8% had hepatitis C, and the general population in the Netherlands has a prevalence of 0.1%, so already clearly higher, telling you that also in HIV negative MSM, hepatitis C is spreading currently. Now the question is, what are the risk factors? And I think it's a little bit more complicated than we believe. It's not that straightforward in the message, but clearly it is related to sexual transmission. You should know, though, that in the context of heterosexual partnerships, the rate of hepatitis C transmission, if people have condomless sex, is very low. And in our own university, we take care of a large group of hemophiliacs, over 800, and only one hemophiliac is gay, right? So 799 are heterosexual, and most of them, if you believe it or not, so at least on the paper, 799 are heterosexual, and most of them have sex with women. And the transmission is only one transmission ever occurs, so it's a very rare event. In the context of men having sex with each other, it's very different, and that has a lot to do with the issue of unprotected anal intercourse, and then if you have multiple partners. So the more partners you have, the more likely you are to have anal bleeding, I think is probably the most highest risk factor. So traumatic sex practices, fisting, sex toys, multiple partners inserting is the increased risk, and there have been studies looking at rectal fluid and the containment of hepatitis C, suggesting that high viral loads in the rectal fluid may contribute to transmission. And then there's obviously issues around the drug use, and we'll hear much more about chemsex from David later on, and obviously that may play a role as well. I have to say, though, that in 2002, there was very little chemsex use. It was predominantly cocaine use at that time, and there was very little needle sharing. So it was not a needle sharing driven disease spread. It was really more through traumatic sex practices, and then some people spread through sharing of snorting devices for cocaine. So you shouldn't forget that if you snort cocaine, you can have nose bleeding quite frequently, and so there's also a risk of blood-blood contact, which may also contribute to infections. And the big issue around hepatitis C, just like with hepatitis B, is that if you compare co-infected and mono-infected patients, the risk of developing severe liver disease remains higher. So even if you have HIV therapy and everything is going well, you still have more liver disease when you are hepatitis C infected and have HIV. And that's why there has been so much strength and push to treat patients with HIV and hepatitis C for obvious reasons because of the disease progression. And I think in medicine, one of the most wonderful stories to be told is the development of hepatitis C drugs. And the HIV colleagues are always like saying, we have this great history. We started with no medicine at all, and then it only took several years, and we got some medicines, and then we got to combination therapy, and now everyone can live a good life if treatment is started early enough, and maybe there will be even cure if Santi holds his fantastic talk and convinces us all of that is possible. But in hepatitis C, things have developed at an even faster pace, and something which was really unbelievable has occurred. So the virus was identified later than HIV. It was 1989 for the first time that hepatitis C was discovered. Before, it was called non-A, non-B hepatitis. And this non-A, non-B hepatitis was already treated with interferon by a sort of crazy guy at NIH. Even prior to the discovery of hepatitis C, he treated his first patients with interferon and showed some benefit. But you can see that when interferon alone was given, very few patients cured. So the goal of hepatitis C always has been, in contrast to HIV, cure. So if you take your medicine, stop the medicine, and are still hepatitis C negative 12 to 24 weeks thereafter, there is no hepatitis C in your body left. So you can actually cure the infection. Very different than HIV. And with interferon, there were many side effects. But when interferon was further developed, was given once weekly with ribavirin, suddenly almost half of the patients were curable. But then, with the advent of so-called direct-acting antivirals, drugs which are given as tablets, work a little bit like HIV, target certain enzymes in the replication cycle, suddenly everyone became curable, and you use no interferon anymore, you need no ribavirin anymore. So suddenly, with very well-tolerated drugs over 8 to 12 weeks, everyone became curable. And that is a huge sensation in the shortest time. And I have to say, because we are living in Bonn, and Bonn is a very small city. It doesn't have a great, large gay community. So most of our patients are still hemophiliacs to a certain degree, and they have been living with this for 30 years. So you can imagine people who went through 2 interferon therapies, and suddenly you can cure them all. The joy you bring to these people is unbelievable. And obviously they think you are responsible for that, which is not true. It's the medication, but they're very nice and treat you all wonderful, give you this big smile. And it's a great thing to experience as a physician, to see how all these patients do so well under therapy. So it's really the hugest medical success story, I think, ever. And the greatest thing for HIV patients was that before, in the interferon era, patients did not respond as well. So if you had HIV, low CD4, you were so much less likely to cure your infection. And then this all changed with these new miraculous drugs, the direct-acting antivirals, and so suddenly the guidelines no longer separate between mono and co-infected patients. All becomes the same. So if you have hepatitis C with HIV or without, it's all treatable and curable, and clearly everyone should receive treatment. And you see here from the randomized clinical trials, just concentrate on the numbers. It doesn't matter which regimen you take. In the end of the day, 96, 97, 97% get cured. So that's the good news. It is treatable. And so obviously, there are things to think about. The only issue you have in HIV is that you also need medicine for your HIV infection. So there may be drug interactions, and so your doctor has to look up drug interactions in commonly available tables in the internet and to see, does your HIV regimen go with the hepatitis C drug regimen, or do you have to switch? Obviously, there are also other drugs which needs to be considered. If you enjoy a lot of chemsep drugs or other drugs, you should note that they also interfere with your hepatitis C medication, and maybe David will say something about that as well, or maybe not. And I think one of the biggest questions in time is, so if hepatitis C is occurring now at a big speed in MSM with HIV, it's treatable, that's good, but you can be reinfected. So it's not that you, after getting rid of the infection, that's it. You can always get infected again and again and again. And there are people in London who have now their 5th or 6th or 7th infection. And that's all related because if there's no change in sexual behavior, no change in risk. And obviously, if you are an IV drug user, You understand the concept of needle sharing is difficult for hepatitis C transmission. You understand that opioid substitution may be useful. All these methods have been shown to work fantastically. They've changed the prevalence of HIV and hepatitis C in Portugal from very high to extremely low, if not non-existent. In the setting of IV drug use, the problem is no longer transmission of hepatitis C. It's a problem of ignorance of political leaders. It's a problem of criminalization of drug users. It's the problem of countries which don't give the proper measures to these people. But if you implement it, like in Portugal, they have shown this is all doable, possible. If you ignore that IV drug use is something which exists, then obviously there is no protection, there's no needle exchange, there's no opioid substitution, there always will be continued use. In the setting of sexual behavior, if I ask you to change your sexual behavior, you're going to say, never ever. So that is very difficult to intervene with. And so one of the big questions in time is, well, if we cannot change sexual behavior, can we change something by treating everyone who has hepatitis C? So just imagine you would be able to treat every person who's an MSM, has hepatitis C, and if there's no one left who can infect somebody, then that would lead to elimination. And the Dutch are very clever and very fast, and they say, well, we have the Athena cohort. This is 20,000 HIV-infected patients from Netherlands. That covers 98% of all infected patients in Netherlands. And then they say, well, look, how many people do we have who have hepatitis C? It's only 1,400. And they have treated now over 80% of these patients. So almost everyone already has been treated. There's only 20% less. And so they said, well, if that's true, do we see a decline in new infections? And they do. So 51% less acute hepatitis C cases. So the hope is that with expanded treatment access, we may be able to control the hepatitis C epidemic by lowering the overall prevalence of disease. And I think it's fascinating because we know our HIV patients. They come for CD4 count control. We can check for hepatitis C. It's much easier to approach that population. Now, obviously, when you do research, there are always people who don't believe what you're saying, right? So people in the audience, the French, get up and, oh, I don't know, it's probably not true, wrong calculation. But then they said, the Dutch was very well prepared. He said, because they said, maybe you're not sexually active anymore. Maybe people just don't have sex anymore. And they said, oh, but we have a 40% increase in syphilis. We have an increase in all other STDs. So in parallel to the decline in acute hepatitis C, everything else which is transmittable has increased substantially. So it's not a lack of sexual action, it's really an observed decline in overprevalence. And I think that is great news because it tells you there may be a way to, yeah, I was not engaged in that, unfortunately. So the risk which remains is hepatitis C reinfection. So if you have, you take drugs, you have multiple sex sessions with multiple people, you take drugs which enhance your sexual performance, and you can have sex with 10 people in a row, there is a risk of blood shedding and blood contact, and you may remain at risk for acquiring hepatitis C, and you can see that the reinfection rate remains high in patients who remain injecting drugs and have no access to support systems, and it remains high in HIV-positive MSM. So that, for us, is the biggest concern, I think, in clinic. I think that treatment for all is the best way out of it, but that's something we may address also during discussion. So obviously, the important thing is once you've had hepatitis C, but also if you belong to the MSM group, there has to be regular screening for hepatitis C, and we have to start talking to patients. You have to ask, are you sharing your injection drug equipment? And I think for me, one of the most shocking things as a physician is that this whole chemsex use of all these different agents is not talked much about in the clinical practice. So we had a recent German ad board, and the physicians were asked, do you think it's a problem? There's a consultant from Berlin, and he says, well, chemsex, I don't really think it's a problem. And he's from Berlin. I mean, all you have to do is go out once in Berlin to see that it's a problem. So you understand that people are not necessarily eager to learn these problems. And another guy said, I'd rather wait till my patient develops clinical problems before I'm asking. But counseling can only be as good as you talk to the person in front of you. There has to be communication, and the community has to understand there are new risks. And if you want to undertake these risks, that's all fine. But you have to know the risks are there, and there are ways to prevent these risks as well. So the last co-infection, very briefly, I want to talk about is HPV. I think this is of concern because, you know, many people have genital warts. These genital warts are also related to human papillomaviruses. There are many, many different serotypes. And again, there are two important things to say. The first is, if we would be able to live in a society which would be open enough to allow people to identify as being gay early, you could vaccinate them. And there are attempts to vaccinate boys in certain countries. In many countries, this is not cost reimbursed, it's only reimbursed for young girls, because girls also can get complications of HPV, in particular cervical cancer. So there's a huge effort to vaccinate young girls now for HPV, but we could also vaccinate young boys, and that would have an impact on preventing their risk for anal cancer. Because as though there are many common benign genital warts, there's also a risk of HPV-related anal cancer, and in HIV patients, this risk is very, very high. And that is the reason why now there are screening recommendations, that varies very strongly from country to country, because the question is screening so much better than looking at someone who has complaints? But I can tell you from clinical practice, you have to talk to your physician that you have discomfort, that there's something weird, something's happening, and that can take some time. And I have to say, I have one own very traumatic experience of a patient who, you know, is there in his regular visit for CD4 count, and I say, is everything fine? He says, yeah, everything's fine. And I had students, so in Germany you have to take students sometimes on Mondays, and the next time he was there were no students. He said, oh, I'm so happy the students aren't there, because now I can really talk to you in person. And they said, I have something in my back. And when he turned around and took his pants down, he had a huge anal cancer. So it's also about, can you find the time and the moment to talk to your patients accordingly. So that's a very important thing to know, that this is another additional risk. So in summary, there are many co-infections which play a role in the context of HIV, but also for MSM who are HIV negative. Clearly there's a need for increasing hepatitis A vaccination with the current outbreaks in all European countries. Also remind everyone of hepatitis B vaccination. Tenofovir is a dual-active HIV-HBV drug which does not only work for those who have chronic hepatitis B, but it also can prevent infection. Acute hepatitis C is really now having a serious outbreak in HIV-positive and HIV-negative MSM. Traumatic sex practices with higher risk of blood-blood contacts are clearly one of the origin. Sharing of needles during chemsex, I think, is increasingly accounting for other infections. And HPV is associated with increased anal cancer risk, and so I think screening is something we probably have to work on. So I'll stop here, and thank you all for your attention. Questions at the end, or how do you? Okay, perfect.
Okay, so my name is Paddy Mallon. I'm delighted to be here from Dublin. I'd like to thank both Julia and Santiago for the very kind invitation to come and speak today, and also for their hospitality also yesterday evening. So I'm a clinician, researcher. I've been working in comorbidities of HIV for the last 15 or 16 years. For the last 10 years, I've been based in a hospital in Dublin called the Mater Hospital. The Mater Hospital is a hospital that is run by a group of nuns, and it traditionally serves a very socially disadvantaged area of northern inner city Dublin. So our HIV population is about 1,300 patients. About 25% are MSM, 25% would be intravenous drug users, and the rest would be heterosexually transmitted HIV with a large contingent from the African subcontinent. We're linked with University College Dublin, and we're the oldest infectious diseases centre in Ireland. We've been open since the 80s. And through University College Dublin, we've been able to engage with our patients to have a very active research program which is focused on long-term safety and trying to understand the aging process in people living with HIV. So as Jürgen touched on, there's been a significant advances during certainly the time that I've been involved in HIV clinical care and research, that we're really getting to the point where for the vast majority of people who have access to treatment, that they will become virologically suppressed on medications that will have a limited short-term toxicity and actually quite a favorable long-term toxicity profile. And I think that needs to be recognized that in a way where we are now in 2017, the advantage is really in knowing your HIV status, because access to the treatments, the availability of the treatments and the safety of treatments is so much better than it used to be. And we can see even in the very early stages of antiretroviral therapy the impact on survival of effective treatment. And these were even during times when we were using treatments that were associated with a lot of toxicity. We still saw a benefit in overall survival from treatment, and that benefit still exists today. And for people newly diagnosed with HIV today, there is even a much stronger argument for getting onto treatment in terms of the survival advantage. As a result of the survival advantage, people living with HIV are getting older, and my focus is not on focusing on what's bad about growing old with HIV, but it's a focus on how we maintain healthy aging and maintain health of people living with HIV into older age. For most cohorts around the world, you can see that the average age is increasing. The proportion of patients living into the 50s, 60s, and 70s is increasing. And therefore, there's a very significant shift in focus for a lot of people who are caring for patients living with HIV, away from the choice and the initiation of treatment, but more towards managing long-term health. And that is a big shift in terms of the types of treatments that we use and the skill set that physicians and other healthcare professionals need to manage people living with HIV. Now, one of the things that's coming through quite strongly when you look at the signals around living with HIV in 2017 and going forward is the importance of the immune response to treatment. We've always been focused on the viral load, and rightly so, because getting an undetectable viral load and maintaining an undetectable viral load is the first principle of treatment. But the more we understand about long-term life with HIV, the more important the immune response to HIV and to antiretroviral treatment is important. To give you an example, this is a long-term study that looked at people living with HIV who were on effective antiretroviral therapy with good CD4 counts, so everyone had a CD4 count above 350. It was taken from 2 control groups of large strategy international trials, so these patients didn't have any intervention other than treatment, but they were followed up for a prolonged period of time, and you can look at overall mortality. So this is a very well-designed analysis looking at outcomes. Now, the way that they presented mortality was through the use of what's called a standardized mortality ratio. So it looks at the mortality rate within a group of patients and compares it to the mortality rate from the general population from which the patients were drawn from. These are international studies, so the general population mortality rates are going to be different country by country. But a standardized mortality ratio of 1 means that mortality is no different within that patient group compared to the background population. A standardized mortality ratio of greater than 1 suggests excess mortality. And when you look at the bottom, it's those people living with HIV on treatment who attain a CD4 count of greater than 500 that have this standardized mortality ratio of 1, so their mortality rates are no different. But there is still excess mortality in those patients who don't reach that threshold of 500. And it's understanding why we get this excess mortality associated with lower immune responses, I think is going to be a key to understand healthy aging as we move forward in HIV. So what are the barriers to reaching a CD4 count of 500? Well, obviously, if you get diagnosed later in your HIV disease, there is more chance that you will have greater immune damage and therefore more chance that your CD4 count will be below 500. We know that people living with HIV who start treatment later with lower CD4 counts are less likely to reach a CD4 count of 500. We know that people, as they get older, their responses to treatment in terms of the CD4 response is blunted. And we also know that there are gender differences. So men, particularly less than females, tend to have lower CD4 responses. So if we want to target at a population level to give people optimum immune responses to treatment, these are the things that we need to target. And that's why it makes sense when you look at some of the global initiatives, such as the 90-90-90 global initiative that I'm sure you're all familiar with. Not only does this fit in terms of a population level at decreasing transmission, but it also makes sense at a personal level because the global community is taking initiatives to try and detect HIV at an earlier stage through increasing testing, to try and get more people on treatment, hopefully at higher CD4 counts in order to preserve their immune health. And I think as Santi is going to cover in his presentation, there's an increasing recognition with cure strategies that the person's immune system is going to be very important with cure strategies if cure strategies are going to work. So at a range of levels, earlier treatment at higher CD4 counts makes sense. Unfortunately, we're not quite there. So this is data from the US, this is similar data from Ireland. And I think what these data demonstrate is that we have the ability to keep people in care, to get people on treatment, and to get people virologically suppressed. But really where we're falling down is in the ability to get those people who are diagnosed with HIV infection adequately linked to care. And what we need to be able to do is to look at each of these steps and analyze each of these sub-steps. I call these gap analysis to try and figure out where it is that we're going wrong and how we can improve the linkage to care and the treatment cascade. In terms of when to start, well, I think really the pendulum is definitely swinging from a scientific point of view towards everyone being on antiretroviral therapy and everyone getting treatment at higher CD4 counts, in fact, regardless of CD4 counts. And I think this makes sense from a European perspective, but when you look globally, there are still huge deficiencies in areas of the world where there's a high burden of HIV. And that's one of the problems that we really need to address is the inequality in terms of access to treatment that exists even in places very close to Europe. If you look at the likes of Russia, for example, where there's really an unchecked, aggressive HIV epidemic, they still don't provide access to treatment for people regardless of CD4 count. And those issues are really going to have to be addressed if we're going to maintain healthier aging with HIV. So what can you expect? Well, if you do get access to treatment, you maintain a good CD4 count and an undetectable viral load, the data at the minute would suggest that a person's lifespan should be equal to, if not better, than would be expected from the general population. And that's why the thinking has to be healthy aging. In some ways, being young, living with HIV with access to treatment may offer you a survival advantage because of the fact that you're linked into general health care and you can get interventions for normal diseases associated with aging at a younger age, an appropriate intervention. And that by itself, as being a positive step in maintaining your own health, can have an overall survival advantage, and that's what's shown here. This graph at the top here is someone with an undetectable viral load and a high CD4 count, and you can see that their life expectancy actually exceeds that of the general population. When you look at what people living with HIV are dying of, these are the types of conditions that they're dying of. This looks startling. We talk about cancer, we talk about cardiovascular disease, a lot of unnatural causes that I think we don't explain that are probably explained by some of the socio-demographic aspects of populations living with HIV. But things like cancer and cardiovascular disease, #1 cause of death in populations living with HIV, but they're also the #1 cause of death within the general population. And the key here is living with HIV leaving people at an increased risk of these diseases versus the general population or not? And that's really where the focus of research needs to be. And the reason for this is because living with HIV is associated with a number of different toxicities or a number of different changes in organs such as the heart, the kidney, the liver, the bone, that are normally associated with these dysfunctions as you get older. And the thinking is when you join HIV together with older age, that these conditions may become either more prevalent or that they may have an impact on people at a younger age than you would expect from the general population. And it's trying to understand this interaction between HIV and normal aging that is at the crux of this research. And one of the big questions that we have is, does living with HIV result in premature aging, or does it not? And I think that it's a question that we need to address for every single condition that we normally associate with aging. It's very easy to say premature aging, but at the same time, you need to have the evidence to suggest that this is actually real. Now, when you look at some very important conditions like cardiovascular disease, for example, there is very robust data to show that people living with HIV have an increased risk of cardiovascular disease, but this increased risk is regardless of your age living with HIV. So if you're living with HIV, even on treatment, your risk of cardiovascular disease is increased by approximately 60%. And that isn't explained by traditional heart disease risk factors. So it's not explained by cholesterol, it's not fully explained by smoking, it's not fully explained by blood pressure. So there is something biological going on, whether it's as a result of the virus or whether it's as a result of treatment, that is offering or attributing an increased risk of heart disease to people living with HIV. What we need to do is to understand that unmeasured risk through research. Once we find what drives the unmeasured risk, then we need to develop interventions that will control that risk. And this is science which is complex. This is just cardiovascular disease. You can see on this side of the slide all of the things that we normally associate with cardiovascular disease in the general population. But when you look at potential contributors driven by HIV or treatment, what you're dealing with are a whole new set of factors that could drive cardiovascular disease that won't be measured or picked up within traditional risk assessments. What we need to do is to take this type of approach to all of the different potential comorbidities and understand what is unique about each of these comorbidities in HIV, and by doing so, then we can develop effective interventions. Bone disease is a very good example. We see increased rates of osteopenia and osteoporosis in people living with HIV. We see increased fracture rates in people living with HIV. But the question is, what is driving this? All of these things contribute to what people term frailty. And frailty, I think, is a very frightening term for someone as they get old. But what we need to be able to do is to understand what contributes to frailty, pick out the pieces, and then start to manage each of the components of frailty to maintain health. And I think the focus needs to be on maintaining health rather than worrying about getting frail. So in reality, how does all of this come together? Well, if we consider what we would call a normal aging process, what happens is that as time goes by, your clinical reserve, whether it be for your bones, whether it be for your strength, whether it be heart disease or liver disease, slowly declines with age, and that's normal. It's a normal process. What can happen is that you can have an event trigger that can lead that process to become more accelerated, and this is what's called accelerated aging. But what can also happen is that you can have a trigger event. So something can happen during your life which leaves you with less reserve, but then you continue to age normally, and that's what's called premature aging. And then lastly, you can have a process where both happen together, where you can have a triggering event that decreases your reserve, and then you can have an accelerated process. Now, what we know from most of the research in HIV is that what we're probably dealing with is the second event, which is an event-driven process that puts us at a bit of a disadvantage from a reserve, but then the normal aging process seems to continue. And I'll show you some examples of that. This is cognitive impairment. There's a lot of research done in cognitive impairment in people living with HIV. On the top is a control population, a very well-designed study with a very carefully matched control population to those living with HIV. And on the bottom, you see those people living with HIV. People living with HIV are at a disadvantage. They have lower cognitive function. But over 2 years of follow-up, there's absolutely no difference in progression. And it's likely that an event has led to that decrease in cognition, but through careful management, we're seeing the person living with HIV or the population living with HIV at no further disadvantage. Similarly, with bone disease, we know what the event is. The event with bone disease seems to be initiation of treatment. This is data from the START study that shows initiation of treatment associated with about a 3 to 4% decline in your bone density. But once you're on treatment, that bone density tends to stabilize. And this is data from one of the cohorts that we have in Dublin called a HIV upbeat cohort. This is about 500 people, half of whom have HIV, and you can see the same sort of graph again. On the top line, you have people without HIV. On the bottom line, you have people with HIV, followed up over a period of 2 years. Although you have the event that's decreased the bone density over time remains stable. And these sort of data, I think, are reassuring in that if we can find out what the event is and prevent the event, we can probably maintain health over time. And there should be no reason why a population living with HIV should not be able to age healthily. So I think this is really what we're dealing with, is describing the event. If we describe the event and know the event, then we can design interventions to try and prevent that happening. So some of the things that we know do work in terms of maintaining health in HIV, well, the big thing, I think the number one thing is smoking. When you look at all of the comorbidities that we deal with, whether it be heart disease, whether it be cancer, whether it be bone disease, and you look at all of the associations, smoking is a huge factor. And if there's one population that shouldn't smoke if they want to maintain their health, it's the population living with HIV. It's a very simple intervention. It's already been shown to have a significant beneficial impact, and it's something I know that within clinic I'm becoming increasingly vocal about in terms of the importance if you want to maintain normal health. But then there are specific interventions. If you have bone disease or loss of bone density with treatment initiation, can you prevent this? And this is a focus of research. This is a study we're conducting at the minute, looking at a short course of bisphosphonate therapy to prevent bone loss as people initiate treatment. So a short 12-week cost of treatment, about €14, could prevent the event happening, so maintains your reserve, and then you can expect to maintain healthy bone similar to the general population. And I think for each of the comorbidities, we need to be taking this strategy. So just to summarize, people living with HIV are living longer. The focus needs to be on healthy living rather than associating age with some sort of negative outcome. There definitely is a benefit, and a lot of the data supports it, to earlier diagnosis and treatment in terms of maintaining health. What we need to do is to understand what contributes to each of the comorbidities, and we need to develop specific treatments and interventions that are tailored to people living with HIV around trying to stop these events happening so that we can maintain reserve and maintain health. The best way to do that is through research. Within Europe, we're really leading the world in terms of researching in older people living with HIV. There are 2 large cohort studies that are looking at all of the different types of comorbidities: heart disease, bone disease, cognitive function. One of them is called POPPY, and it's developed within the UK and Ireland, and the other one is AIDS HIV, being developed in the Netherlands. These studies are up and running. We're already starting to get very good data from them, and I think the data from these studies will really help to shape the type of treatment and the best management for people living with HIV as they get older. Thanks a lot for your attention.
Buenos días, amigas y amigos. Deciros que estoy encantado de estar aquí hablando para vosotros y por muchas razones. Una por esa.
That I'm talking to you. And I'm very pleased to have this opportunity to be here with you in this conference in the setting of the World Pride. It's a pleasure. And I'm very happy to share this table with people I really admire and love. So my relationship with, for example, with Julia, it goes beyond our profession. We have a friendship, and this is a reason of joy. I am pleased to talk to you about the healing of HIV. And this is obviously, this divides the scientific community into groups. Those that believe that is viable and accessible is going to happen soon, and those who believe it's a very almost impossible, very difficult task. So I hope you share my optimism after I share my talk to you, that it's, in my opinion, something which is viable and accessible. My intention is not going to be to review all the progress we have made around the healing of AIDS. I just want to give you the basic ideas, but necessary so that you can understand what we're talking about when we talk about the healing of HIV. Are we witnessing the end of AIDS? It is possible. There are different ways of approaching this topic. As you know, there is one way with which to try and diagnose all the people who are infected by this virus and start treatment as soon as possible. If we did this, we estimated that we wouldn't have any new cases by 2020. So this would be a very good way of controlling the epidemic. So we have to diagnose all the people who carry the virus. And this could be carried out in all the world. Okay, the second is the vaccination. So we are looking for a vaccination that would allow people who are infected, actually, it would prevent the infection within these communities. So we would eradicate the epidemic eventually. And the third point is the one I'm going to talk about, which is the healing. This is what we are looking for. And this would affect only to the people who are already infected or are going to be infected shortly. So it's about maintaining a good quality of life, as normal as possible, without the antiretroviral treatments. Because, as we know, it has a very serious side effects. And I'm going to talk about also the resources necessary for this third option. So why HIV infection is not curable, despite having a very efficient treatment that we have and has wonderful effects? I'm going to explain this. In this graph represents the viral count that an individual has in blood and the years of retroviral treatment. So So depending on the viral account, they will have to take, the treatment will be longer or shorter. So in these levels, when it's not easy to, when we can't detect it, because the virus hides and it doesn't show in the blood. So this happens at the same time as if we increase defenses. This is the immediate effect that has the retroviral medicines. So the defense mechanism is strengthened. If we interrupt the treatment, however, virtually in all the individuals, we would say 100%, the virus comes back, emerges again. So the virus may have been there 3 years under control, but then it comes back. We have also seen that if one looks for it, the HIV is always present. You see, the virus is integrated in our cells. There are no individual, there's no person that doesn't have the virus if we look for it. It's hidden somewhere. So between 0 and 50 copies that are detected by the machine in the laboratory, there is always the virus. This is what we call it, the residual viral count. So the idea is that despite the correct treatment and having the levels of virus count and increasing defenses, the immune system, the virus remains in blood in the majority of individuals who have had the correct treatment. So nowadays, it's this virus that I have shown that re-emerges, even with treatment. Where does it come from? And even though after all these years of research, there's no unanimity as to where this virus that comes back, where does it come from? So there are two possibilities. It could come from what we call the anatomical reservoirs. So the drug doesn't reach these reservoirs properly. For example, the central nervous system. There are small concentrations of the virus, but it could be hiding there. And this possibility is not contemplated as the most important one. The second possibility would be that despite the efficient treatment, the virus continues to replicate. So the treatment doesn't reach the tissues, and there's a small amount of virus that replicates themselves. These, among the researchers, there's no agreement, as I said. Some people believe that the treatment is not powerful enough to kill the virus, and some other people believe that that's not the point, because the virus is effective. And nobody questions the third question, which is these cellular reservoirs. These are cells of the defense mechanism that are infected in a latent way. I'm going to explain this by HIV. And nobody questions, and this is the main barrier for the total eradication of the HIV, of the virus. I'm going to explain this briefly for you to understand you, because this is a key issue, because what has been done at the moment is related to this. There's a type of lymphocyte that we have in our body. Is the activated lymphocytes. These are activated, and so with the virus, they replicate themselves. And some other lymphocytes that do not replicate themselves. So these blue ones, if these ones are infected by the HIV, they do replicate. The virus multiplies itself, But that's not the problem, because with the retroviral treatment, we can prevent them from infecting new cells. So we end with the virus, and that would be it. But that's not the only problem. And this is what we have managed to control nowadays. But the problem doesn't come from this side of the issue. The problem is this: when the cells are infected by the virus remains there, integrated in the cell, and it doesn't leave, it doesn't get killed. And that's the antiretroviral treatment is only efficient with the cells that multiply themselves. But if it's inside the cell, then this kind of treatment doesn't work. They will remain there forever. So apparently, this reservoir comes from the direct infection from the virus. And all the cells that are infected, some of them, they seem to go back to a resting state. So all the cells, without exception, all the people infected, they have a reservoir of C cells that are permanently infected by the virus, and regardless of the amount of years they go with treatment, they don't get healed, they don't cure themselves. And this is what I want to talk about here. If our strategy to eliminate the T cells would be to activate the latent cells, what we tried to do is to transform this virus, which is resting, to activate the virus. Then we'll be able to eliminate this reservoir. Do you understand the strategy? So we are going to activate these resting cells in order to kill them afterwards. So if you see, in 94, 95, it was published in the Time magazine, a mathematical model that calculated that giving antiretroviral treatment between 2 and 7 years, the infection would be healed. Do you know why? Because they haven't discovered the reservoir. So he thought, in a couple of years, with good treatment, we can kill all the infected cells. And that same year, we discovered the reservoir, and so we discovered that this reservoir is very stable. We would need 73 years of antiretroviral treatment in order to kill it. So that's not very optimistic. If you tell a patient you're going to be healed in 73 years, it's not good. Therefore, new strategies were tried in order to speed up the process of killing these reservoir cells. And this is where we are now, trying different strategies to eliminate the latently infected cells, which exist in this reservoir. So the most popular strategy, which I don't think is going to be the most successful, this is what we call the shock and kill. This represents the cell, lymphocyte T, which has been infected latently. So the first part of the strategies would I have explained, to give drugs that activate this latent virus in such a way that the virus replicates itself, the cell transforms into an activated cell, and therefore our own body ends with this cell. Do you follow this so far? So this is the hope. So we're going to use a drug that is called activated agents of latency, and we could kill them afterwards. So we have drugs that reactivate this latent state, and they get given, and they still don't work So we see that this reservoir is still very stable. And so we have very many drugs like this which are available. And you know why they don't disappear? Because the cells that should be in charge of killing the ones in the reservoir are also infected, and they have lost their power. They are toxic, if you like. They are toxic cells. They should be able to eat them, but they are ruined by the chronic condition of the VIH. So what we are trying to do now is that part of the killing. So trying to reactivate the cell with other strategies. For example, vaccinations, therapeutic vaccinations that reanimate the cells which are in charge of killing the reservoir. So when we go to a Congress, we are hoping that a new experiment is going to show that this shock strategy is working. I don't know if you remember last year in Barcelona that this theory was protected, and a clinical trial was presented with a drug that was activated the latent cells, and a therapeutic vaccine that would give back these good cells their effectiveness. So we are still advancing in strategies of this type. If you understand this strategy, you are going to understand any talk related to the new approaches and these two steps. So, is it possible then to be cured of HIV? When we talk about being healed, we talk about two things. We're talking about healing of any infection disease, so you eliminate all the virus, all the virus that is infecting a person. That means sterilizing cure. There's no remains, and this is really what we do not intend this, because it's very difficult and probably unnecessary. So what we call the remission, that would be a second model. So you eliminate the majority of the infected cells and the virus, and the little bit remaining can be controlled by our own bodies, our own immune system. So this is what we call functional cure. So we really talk about we think about functional cure when we talk about HIV cure. However, a total cure is only depending on the individual. And there has been a case, and apparently this person managed to kill all the virus and has an sterilizing cure. Sterilizing cure. This person is American and lives in Berlin. Have you heard about this person? Timothy Ray, who was infected by the HIV and was having a very good progress. And then had leukemia, and so he needed a transplant of a bone transplant, bone marrow transplant. And after this transplant, the person who was in charge, the doctor, had a brilliant idea. You know that some infected people, they need to use two receptors. The CD4 and CCRT. So if they don't have these two receptors, the virus can't enter the body. The majority of the population only do not have this receptor. Okay? So the specialist who was in charge of doing the transplant thought of what would happen if he found the marrow bone of a donor who had this receptor, which is rare. So the person couldn't be reinfected. And this is what he did. And this was a really brief report, change the history of medicine of AIDS. So this there was the bone marrow transplantation, and they stopped the antiretroviral treatment. As you can see, the virus kept very low. It didn't come back. There was a brain biopsy. There were different types of biopsies looking for the virus, and the virus wasn't there. This was published in 2009, and we are in 2017. So we have carried out more studies, and the virus in this person has not reemerged. In this individual is the only person in the world who apparently has not developed the virus again, okay? So this model hasn't been able to reproduce because, you know, it had to have a transplant, which is very difficult. So it's very difficult to find a donor who has this receptor, the CCR5. So in the case of Timothy Brown, is that the latent infected cells were able to be, we were able to eliminate them. I can give you some more examples, but his case was the first one, and many people have tried to emulate it, but obviously it's very difficult to find a donor who has these receptors, CCR5. So here you are, patients who have been stable, and with transplant, with bone marrow transplant. So, and then the antiretroviral treatment was stopped, and in different periods of time, with a difference of 70 days in the first one, 200 and something days. You see the virus reappeared in these other cases. We weren't able to eliminate it totally. So apparently the co-receptor CCR5 was very important. Some years ago, also, it was very important that there was a little girl in Mississippi. There was another case that was born from a HIV-positive mother, and the mother during the pregnancy didn't have any treatment, so she was born being HIV positive. She received the antiretroviral treatment since at a very early age, and she remained without the virus. So they stopped the treatment, and one day when she went back to hospital, they discovered that the virus was not detectable. So we realized that because we started at a very early age, the reservoir didn't have time to form, you see? So the idea, the very, very early start of the treatment could end the reservoir, but some months later, the virus came back, re-emerged. And again, Timothy Brown's case has suggested having some genetic engineering cases, ideas or strategies in order to end with the virus, because it's very difficult to find, again, donors of bone marrow with this receptor. So here what they've done is to take the CD4 lymphocytes. They have some enzymes which are represented as a zizzer. So if you take these lymphocytes and you incubate them with this enzyme, you do have CCR5. So the cells that were CCR5 positives, now they become negative. You see, it's your own cell. So these cells, then they expand in order to have very many, and they can be injected into the individual, so they're their own cells treated, and then they become CCR5 negative. So these, then we would expect that the same thing that happened with the transplant, and in fact, it hasn't worked. You can see here how in all the patients the virus reemerged, okay? And just in order to finish, you see we have focused on the reservoir, and in the last couple of years, a new trend has emerged. And this comes from oncology cases and approaches. So I'm very favoring this new trend. So especially say in oncology and HIV are very similar in terms of cure, because we are looking at cells, and we have to eliminate cells that the immune system does not recognize and they persist. Therefore, why don't we apply to HIV the same knowledge that we have in oncology and are producing very good results? So, if we compare what we need in order to cure HIV and cancer, if we compare these two things, they are very similar. So many that in this slide that I have borrowed from a researcher, you see this is a scheme of how, we don't need to read it, I don't understand it either, but it's just how we treat a cancerogenic cell. So it's very, very similar to the way we treat HIV-infected cells. So forget the virus, the HIV virus. Just speak about think of a cell that we need to eliminate. And that's the question. So in this year, in July, there is a forum that is called Cancer and HIV, because they are going to study this in a parallel way. This is very much my line of thought, that I believe that in order to cure HIV infections, we're going to have different strategies. To eliminate the majority of the virus, we need to use retroviral drugs. Also, activating agents of latent cells. And so we're going to have one or more of the strategies that are being used nowadays to treat patients with cancer. So, for example, these blockers of the immune system, and this has been started to be the case in patients with HIV. And this, I think, is the strategy that we're going to see in the years to come. Okay? So, as I say, I'm optimistic. And I think there's going to be a very significant improvement in the persistence of the virus, our knowledge of it, and we believe that in some individuals it's possible to eliminate this virus throughout the time. It's also clear that the long-term control of the virus replication in the absence of retroviral treatment is possible. So what we have learned, that we can actually translate these lessons to feasible and scalable interventions. And finally, the combination therapy is more likely need to achieve HIV remission. So we need to keep optimism, and we're going to celebrate it very soon. Thank you very much.
Muchas gracias a los tres ponentes por tres charlas maravillosas y por haberse ajustado al tiempo. Tenemos unos 10 minutos para preguntas y comentarios, tanto para Jürgen, Paddy o Santi. Si alguien se anima, en la primera fila tenemos una pregunta aquí, por favor.
A ver, mi pregunta.
Well, my question is for Jürgen. You were saying that the seropositive, my question is there a vaccination for hepatitis C? I heard something, but I don't know if it's true or not. I suppose you are very aware of what's going on. Microphone, please.
There's still an effort to develop a hepatitis C vaccine because many people believe that only with a vaccine you can sufficiently prevent hepatitis C infections, but there is no licensed currently available vaccine which works. So only for A and B, not for C. And that's why sort of prevention has to happen differently.
And human papillomavirus as well, he was asking.
And human papillomavirus, there is a vaccine. The only problem is, like, if you want to be vaccinated now, it's too late. So most people get HPV infected very early after the first sex. So the best is to be HPV vaccinated before having sex for the first time. That's why young boys and girls are the target group for intervention. But for patients now, most of them already have HPV, it's too late. No? Sí.
Esa creo que es.
I think that is a very important matter. You've seen there are defenders. It's debatable, but there are people who defend in the government the use of the papillomavirus for HIV people, no matter how old they are. Adding to this that they can cause a certain degree of protection against the cancerous development of cancerous lesions. And this is important because there's another current of thought, but there are many people who could come to look or to purchase a papilloma vaccine to cure themselves. What is your opinion in this sense? And Patty, what do you think about this?
Un questione complicado. That's very complicated because everyone says something different, right? So at the EX conference, at the Glasgow conference, Deborah Konipke from Belgium gave the talk on human papillomavirus, and she said she still sees potential for vaccinating people even after HPV infection has occurred. And some of that is the belief that the vaccine may cover serotypes which are not already present. But no one has looked into that and really said, well, you have only 16, 14, 30, and 23, and maybe we can protect you against 37. So I think the clinical utility is not proven. And that's why there are other people in the field who are very reluctant to strongly recommend vaccine. And we just had the current discussion also in an interesting patient, because it was an Arabian patient, non-HIV positive, who had all these anal HPV infections. And you wonder, how did he get that? Not possible to talk about it. But the question was, would it make sense in the setting of a normal immune system, would it make sense to vaccinate him in the hope that there's some protection from some of the serotypes he doesn't have and so forth? And no one really knows. I vaccinated him because I felt it's going to do no harm. But the data is not very clear, and I think at this point there's no clear recommendation to vaccinate people when they're already older and have HPV infection.
So in Ireland in the last 6 months, the government made a decision to make HPV vaccination available to all people living with HIV. And I think that was done under the understanding that there could be a potential benefit versus the perceived lack of harm from vaccination.
Yeah.
And when you think about the rationale, the biological rationale, to me it makes sense. If you have if you've only been exposed to some serotypes of HPV and you can be vaccinated against other serotypes, why not? I think as you said, when you see a case of bad anal cancer, or I've seen a couple of cases of very bad penile cancer, it's devastating. And if I thought that I could prevent that through vaccination, I would. But I do think we need to continue to gather the data. The problem we have is we've got a very effective biological vaccine, but we don't have the clinical benefit data. And it's what to do while we wait. I think it makes sense to me to vaccinate, but to continue to collect the data to show that what we're doing is actually having a benefit.
And you know, in all fairness, you have to say that the vaccine doesn't cover all serotypes. And if you go into Zambian women, they have more serotypes than the vaccine. So it's also a little challenge because you have places in the world where there are more serotypes than even covered by the vaccine, and I think the protection rate in certain African populations is going to be zero because they have all this high distribution of different HPV serotypes. So it's difficult. The question is, how many serotypes do gay men have, and is there room for that?
Many, a lot more than women.
Yeah, exactly.
And the vaccine comes at cost. So I think it's a matter of saying, do we want to spend our money there, or do we want to set up anal cancer prevention programs, which is actually something that we probably need to do more, and this needs to be done in the context of men's health, sexual health.
I think for me, the issue is probably to come to a better algorithm of how to screen people, because if it's your research focus. So if you're working in an HPV group, everyone gets screened and probably gets screened more often than they really need, right? And people get completely, over panicky because of all these screening, and so there's also, I think, an issue. But I think there are also clinics where everyone is undetectable, CD4 count is great, and no one does a physical anymore. So, there has to be a compromise between just taking labs, but also dealing with a patient who's getting older, and we deal with other issues, and they can take his clothes off intermittently, because I think that's one of the issues.
No, and this is a very relevant question for gay men. Very important question for HIV-negative gay men as well. And I agree with Jürgen that the evidence, the clinical evidence, is still to be developed because we don't have enough. Going on the hepatitis A, Jürgen, have we done enough prevention in hepatitis A? When it seems that we've done the very difficult part in hepatitis C, and we're also happy that we've achieved so much. And when you think about Hep A, preventable through a vaccine that is relatively cheap, that's been around for a long time, do we need to do more?
I think we need to do more because, that hepatitis A outbreak, and I think it's just what we have to remember. If a virus enters a community which is very active and there are many contacts, it will spread like fire. And if we sort of think, well, hepatitis A, no one has heard of it anymore, it doesn't play a role anymore, so the vaccination uptake goes down. And it really reminds us, if we let our coverage slip down, we are at a substantial risk. And it's amazing because you read it, and I was doing the inpatient last week, and the first patient who was admitted was a 21-year-old with hepatitis A, and he was HIV negative. But it tells you the whole problem in Germany is obviously there is no special doctor for MSM, and for, and so someone has to go to his family doctor and say, I'm gay, and then the guy says, oh, you have to get vaccinated. And now there's birth date vaccination. So for most people who are born today, it's no problem because everyone gets vaccinated. But for those from 20 years ago, they didn't get vaccinated, and they are at a risk. And this outbreak, which happens in all cities, so once it's there, it's going to travel with every World Pride and every Euro Pride and every Gay Pride. It's going to travel and lead to an outbreak, and it's all preventable. And and you don't have to be in the hospital and all these sick things. And so I think so. What we're going to do now is, like I said, starting from Monday, everyone will get a hepatitis A and B serology, and we'll check within the next 4 months how many people have a negative vaccination set, just to see is it how prevalent is it in our cohort, are we really following vaccination it just reminds you have to remember doing these things and remember that hepatitis E vaccination also needs some refreshment, and so that's important to keep in mind.
Hay que vacunar a todos, hay que vacunarles, no por nada.
We have to vaccinate everyone. In Madrid, the number of hepatitis A cases, the big cases, have increased enormously in the last year. Up until now, we hadn't been systematically vaccinating because of two reasons. Because the first generation we were seeing, most of them were A positive. They'd had it in their childhood. So the second reason was we didn't see a high incidence of hepatitis A in our patients. So therefore, we were doing it routinely, but by conviction only. But today, it's a sin not to vaccinate because exposure involves many patients and people with that get a very serious hepatitis A and have to be hospitalized and can be just terrible cases. So let's vaccinate. And the evolution of hepatitis C comes in, and we don't have a vaccine there.
You mentioned smoking, and I think this is very important to mention smoking cessation. I don't think we've paid enough attention to the issue of smoking in HIV-positive people. What is your experience with your smoking cessation programs? Are you successful? Are you disappointed? Do you need...
So, I guess the first thing is this is what we would call general internal medicine, and a lot of physicians caring for people with HIV over years were very good at all the names of the drugs and all the doses and all the drug interactions. But when it comes to basic health promotion and what we would call primary and secondary prevention, sometimes we're not up to speed. And you see that in the clinical studies. You see, we know so much about all of these diseases, yet upwards of 50% of patients still smoke. You look at blood pressure management in cohorts of people living with HIV, it's very poor. And I think that focus is slowly changing. Smoking cessation is difficult. I don't think that there is any one standardized smoking cessation program format that's been shown to be really effective. Personally, I think the most effective way to quit smoking, because it worked with me, is just to keep annoying the person who's smoking to the extent that they get so fed up being told that they're doing something wrong that they stop. But I think that to me it needs to be within the clinic, it needs to be outside the clinic, it needs to be part of the community, it needs to be the message, because it's such a strong contributor to so many different conditions that just the removal of that one contributor would have a huge positive impact on a whole range of conditions. Lung disease, cancers, heart disease, all of these conditions can be improved through smoking cessation. So it needs to be in the clinic, it needs to be at home, it needs to be socially, it needs to be a general health awareness message. And I think I agree with you that it's something that we haven't done enough of as both physicians, but also within the wider community to address general health in that way.
Thank you, Paddy. We have a question.
Sí, es que tenía una pregunta para cada uno.
I had a question for each one. The next is for Patty. He talked about the cognitive deterioration. Wanted to know what that's like. I mean, does it affect the neurotransmitters, dopamine, or could we have Parkinson come up? I don't know.
It's a fantastic question. The key here is when we talk about cognitive dysfunction, how we measure it, and there's lots of different measures, but generally cognitive function tests revolve around testing your cognitive abilities, so you know your memory, how well you can calculate, so really like higher level function, but also your mood. And the more that we know about people living with HIV, we know this from the POPPY study, one of the clear signals that came through was that psychiatric concerns, specifically depression, was much more common amongst people living with HIV versus people, you know, gay men or heterosexual men or women without HIV. And it may be something much deeper, something psychological or depression or lifestyle that's, we talked about these events. These could be events that are continuing in people living with HIV that when we go to measure cognitive function, show it to be lower. Okay, when you go and you look at the biology, you see signals, you know, you look at MRI scans, you see some subtle differences, but the big clinical difference is, in my view, is depression, and it's the prevalence of even mild to moderate depression. It's not that everyone living with HIV is very sad, but even these mild changes in your mood can have knock-on effects on how we measure cognition. And I think it's that level of understanding that we need to further develop, but these are all relatively new findings coming from these studies of older people living with HIV, which I think are very valuable.
Déjame que, por una vez,
Please let me for once digress. I'm not convinced, Patty, that there are neurocognitive disorders associated with HIV. Honestly, I think that it's more about a world that has been formed around it, promoted by a very specific group of people in the U.S. And in my patients, I don't see any disorders, none. And if I look at the cognitive tests that they take, I would fail each one. I would be anxious, have lost my memory. I say this honestly because if you compare people with HIV to people without it, let's compare them to people with chronic diseases. Let's look at people in the cardiology department and people in neurology with chronic disease, and let's compare things to them. These are people with chronic diseases who are being attended at the hospital. I think that HIV, honestly, per se, with antiretroviral efficacy is what least worries me. Zero.
So, can I extend to that?
I think, first of all, I think you have to separate three different scenarios. The one is you will have patients who develop clear signs of cognitive impairment, so they get psychotic or they can't remember anything, and you tell there's a neurological disorientation of whatever sort. And when you examine them, you will find out that they're usually undetectable in the viral load, but if you do a CSF puncture, they're replicating in the CSF. And if you then change or increase drugs which penetrate, they actually get much better from a neurocognitive standpoint. So I think there's this very, very small, rare group, but there is an issue in some patients who have replication in the CSF, even with resistance emergence, but are still controlled in plasma. So that's one special group. Not very high numbers, but that exists. And then you have a general, like in the German Competence Network for HIV, 50% have a depression, much higher than in the general population. And the question is that just because coming with HIV and all the issues of how to tell it my family, the next sex partner I have, blah, blah, is this just a matter of chronic disease? That's what you're referring to. It's just something which comes with any disease and may not be that relevant. On a neuroimaging and functional MRI level, so if you do tasks like you do a calculation task or you have to pick certain colors and you repeat the test, HIV patients are much slower in doing that. So there is a change on functional MRI level. The question is that something which makes you less likely to find your key or to find your way home after drinking 3 glasses of red wine, yes or no? And I think that's something you don't see. That's why you say I don't see that, but we don't know yet. And I think you have to be fair that if inflammation, which is happening in the CSF, cytokines, neurocells are infected, and the same is true for the liver. Liver enzymes are elevated because HIV can infect hepatic stellate cells. The question is this inflammation in the brain, inflammation in the liver, inflammation along the vessel system, is that all going to lead to more complications? It's easy in the context of stroke It's easy in the context of MIs, it's easy for us to measure, and we know that is increased. But there's at least a rationale that increased inflammation over decades of HIV infection will also lead to more complications. And is that potentially already seen by higher depression rates? Very difficult to say, because people with a chronic disease have more depression than people without a chronic disease, right? So that sort of, I think, is where it's unclear. But I think you can't say it's not at least possible, because I think there is a strong rationale from all the work in that group. And yes, it has been commercially used to say you have to use this drug over that drug, and that's not the right way for research to develop. But I think to spend some time and energy to understand, is this inflammation in the end going to lead to changes, I think is important.
No, pero
So I agree with both of you.
That's always good.
But to me, the reassuring thing is when you look at it, the studies that have looked at people over time, people living with HIV do not get worse. And that to me is reassuring that, as Santi said, when I look at the people sitting in front of me, for the vast majority of my patients living with HIV on treatment, I don't see them coming in developing dementia, developing more neurocognitive impairment, and the studies support that. As Jürgen said, the key is to identify the small proportion, very, very small proportion of patients for which this is an issue and be able to act on it. But at the same time, for the vast majority of people living with HIV, people are afraid of their brains and of something happening to their brain. It's something it's natural. I don't think we should be reinforcing that to say that something bad is going to happen, because I don't think the data support that yet. But we need to continue with the research to sort of understand, is it inflammation, are there psychological aspects to this, and by doing that then I think we'll be able to inform people of how to stay healthy, because that to me is the key.
yo creo que
I think that we're saying the same thing. The matter is, the inflammation can be important, but when it affects bones, it worries us because there are clinical consequences. When it affects your liver, because we see it. But in the brain, we're not worried because we can't see that. Right? That's.
I'm aware of time, so let's move forward. We have one more question, and the lady next to you, another question. Grita.
Speak loudly. No. Sorry, he's not using the microphone yet. He needs a microphone. Hey, ask him to start over. The question is, how can we get CCR5 negative bone marrows to people who need a transplant, and could they really benefit from this? I'm sorry, he's not using a microphone, the guy in the audience. Well, we've created a bank of donors CCR5 negative. So if any of us has a patient who needs, because of lymphoma or whatever, needs a bone marrow transplant, we can see if it's compatible to something in our bank. And to eliminate one of the problems, we have mother cells, stem cells with the umbilical cords. But the bone marrow transplants, it's always making sure they're compatible with all the other antigens that can avoid rejection by the patient. And it has to be compatible with all the other antigens with the donor. Okay? But you should know that a bank and a registry of donors of CCR5 negative has been created. We have a last question here, and then we will close our session and go to lunch if you think that's all right. Hello, my question would be for Jürgen. I hope I can explain myself well. So once you have undertaken treatment for hepatitis C and you've negativized it, does this mean that you're 100% cured, or would it happen like what happens with AIDS virus that's latent but still there? Thank you.
Great question. So, hepatitis C is very different than HIV and HPV because it's not integrated into the cell in the same way as HIV and HPV is. So even if you get rid of HPV, it can always come back when you get chemotherapy for cancer. For hepatitis C, when it's cured, it's cured. It's really gone. You can't find it anywhere anymore. And thousands of patients have been followed up to 5 years after cure, and you look, is there anyone who has hepatitis C again? And really most of these cases where it comes again, it's a reinfection. So there's really no late relapse or somehow it survives in the brain or somewhere else, no. So once hepatitis C is gone, it's gone. And that's because it's so much easier to eradicate because it's not integrated into the DNA. It's not living in latent infected cells, no. So that's why hepatitis C is easy to target and it's gone then forever. But you have no protective immunity. The immune system does not gain the competence to get rid of it. So if you get exposed again, then you have it back again.
Gracias, Jürgen. Gracias a todos por la...
Thank you, Jürgen. Thank everyone for your questions. I think with this positive note, we can, that Jürgen has given us, we can close the session and thank the speakers for their clarity and their proximity to all of us. And we will continue this afternoon and throughout this important week for all of us.
Detrás está el catering otra vez y bueno, que ya se estará quedando un poco frío porque vamos un poco tarde.
At 3 o'clock we will be back here for the afternoon session.